We have a guest on our program who's not in the studio, but off to the side. I feel like I'm whispering like Ralph Edwards. Can he hear? This is serious business. May we see that picture, please? This man suffers from apnea. Do you know what that is? He stops breathing while he's sleeping. And it happens many, many times each evening. Can we, I think he's actually sleeping right now. He's in the company of Dr. Michael Thorpe, who's director of the Sleep-Wake Center at Montefiore Medical Center here in the city. Let's see if we can hear him breathing. I hope he's breathing. Can you hear me, Dr. Thorpe?
Yes, Phil. He's breathing very shallowly at the moment, and he's just starting to go into sleep. He's in a very drowsy sleep at the moment, and within a few minutes we expect that he'll go into a deeper sleep and we'll start to see the apneas.
Okay, we'll be back with you in a few minutes. We thank this man, whom we shall identify as Gary. He's a 53-year-old Long Island court reporter. He tells a very sad story. Take his picture one more time, Brian. He, in front of 72 prospective jurors, woke up to find everybody laughing at him. Apnea victims, when they snore, it can be quite a distracting. These are people, quite literally, whose body is saying, "Holy cow, this is an emergency," and let me let a doctor do the talking. Dr. William Dement is PhD and an MD. You're a professor of psychiatry and behavioral sciences, director of the Stanford University Sleep Disorders Center. How many of us are suffering from apnea?
In this condition, certainly millions of people. Population surveys are spotty, but at least 1% of the general population, maybe as high as 10%.
Now, this is not to be confused with narcolepsy.
Right.
Narcoleptics are the people who fall asleep in the middle of a conversation or while driving a car. Apnea victims sustain their most inconvenience during the night while they're sleeping.
That's right.
And how many times a night would they stop breathing?
Well, it could be as high as 750 times.
I don't see how you survive that. That sounds...
Well, fortunately, there are alarm systems in the brain that respond to this very dangerous condition, and we sort of arouse. Then arouse and breathe a few times, fall asleep again, and that cycle can be repeated over and over again throughout the entire night. And
you find out whether your spouse really loves you, I bet you.
That's right.
This can be a very big agony for the spouse.
Oh, yes.
Ralph Newman is here. You're president of a New York advertising agency.
Yes, I am.
You're 43, and you do not look it. You could be 33.
Well, thank you.
You're married 11 years, and you suffer from this, from apnea.
Well,
Sleep apnea.
I did suffer from it until it was corrected. I would add to what you said, that it does affect you during the day, very much so. Every day about 1 to 2 o'clock, I would start nodding out. I would have memory loss. I would slur my speech.
Really?
I would forget phone numbers, and it was a very devastating experience.
Yeah. What do we know about this? Drug addicts die often, not always, but a drug victim is usually a person. The drug has so relaxed them that the body quite literally fails to tell the brain to execute the breathing mechanism.
Well, I think, for example, narcotics, there's definitely an effect on respiration, but after someone dies, of course, it's hard to know the reason, but there have been studies of alcohol in this condition. Alcohol makes it worse. If you take alcohol before you go to bed, you have more apneas, they may be longer, and it sort of depresses the brain. The brain needs to be able to wake up, and anything that depresses the brain tremendously increases the risk.
Yeah. Mr. Newman, I assume you felt drowsy. When did your drowsiness hit during the day? Were you a lark in the morning feeling very good?
I got up in the morning not feeling bad, certainly not terrific. And I'd say 1 to 2 o'clock in the afternoon, it hit me hard and got progressively worse from there. And I would crave sleep in the worst way and wasn't able to get it.
See, there can be a tremendous range of sleepiness. Some people are literally not awake at all. Fall asleep standing up, fall asleep while eating, fall asleep with the head in the spaghetti, fall asleep even during sexual intercourse. Then there can be less severe, but...
You could have spent the whole show without giving us that example. Well, it's okay to laugh, but boy, it must be rough
No,
when
it's a living death at its most extreme.
What'd they do, Mr. Newman? What was the surgery?
It was a type of what I understand to be a cosmetic surgery. It's called UPPP, uvulopalatopharyngoplasty.
I knew that, but I'm glad you shared it.
And it was a tightening up of some tissues at the rear of the throat and the removal of some others, and an opening of the airway.
And you feel better now, huh?
I feel like a teenage kid.
You don't have this anymore.
Absolutely not.
No midnight emergencies of...
None whatsoever.
This can be fatal.
Yes. And
If the body doesn't kick you in...
That's right. And I think there are many ways that it can be fatal. You could fall asleep while driving a car, for example. And say, in some of the, many of the cases where people fall asleep are killed, we don't know what happened, but we suspect this kind of problem in some cases.
Lois has joined us to make the following point. You suffer from narcolepsy.
Yes.
I'm still not sure I understand the difference.
Oh,
You-
there's a big difference. Yeah.
Well, he feels drowsy too, and so did you, right?
But I sleep it. I mean, I can breathe when I'm asleep. I don't snore.
I see.
It's different.
But you have fallen asleep at inappropriate times,
Oh, yes.
for example.
Oh. I've fallen asleep. I guess the most dramatic was when I fell asleep in the bathtub.
You could have drowned.
Well, I was drowning. My daughter saved my life. Yeah.
You could feel yourself going, and you couldn't do anything about it.
No. No, the paralysis mechanism went on.
And you just feel like you're floating, or is there a sensation to this?
Just drowning.
I want to show the film of you. This is a couple years ago that this was filmed.
10 years ago.
10.
10 years ago.
And it's your daughter with you here in this
Yeah.
film. This is from a documentary on the issue of narcolepsy. Watch
What's
this.
the matter? What's the matter?
Oh, yeah.
You want to get up? You want to go forward?
Wake up, wake up.
If you get upset about it, it's going to get worse. So don't get upset about it. You're going to make your mind a blank now, so you're not thinking about
No, put forward.
it. Lean forward.
Okay, man, I'm talking.
All right, let's talk about something.
My nose are hurting. No!
What? Okay, you got it. You can move now.
Okay.
Right, so talk about.
Something else. Huh?
That was cataplexy. We haven't talked about cataplexy.
Tell me about it.
That was an attack of sleep, but an attack of REM sleep. And we're all paralyzed at night when we dream. Everyone in this room is paralyzed when they sleep at night. Well, that happened to be an attack of REM sleep, and I became paralyzed.
See, the basic essentials of sleep, the most fundamental factors are two entirely different kinds of sleep. One is called REM sleep, in which the brain becomes very, very active. And
Rapid eye movement is
Rapid
the-
eye movement sleep. We dream vividly in that state, and at the same time, the brain blocks all of the motor impulses. So it's like we're trying to move, and at the same time, we're blocking our movement. And that blockage results in a total paralysis, with the exception of the diaphragm. And so when you have an attack of REM sleep, it's called cataplexy, the first manifestation is paralysis, weakness of the muscles. Then you can go right on into the dream state.
So you can hear in the twilight zone your daughter saying, "Come on, Mommy, come on," and yet you can't move.
No, I can't move.
Is this a lifelong condition, is it?
Yes, it begins usually in the second decade, particularly in puberty, and then it's chronic and present all lifelong. I don't think we know of any single case of remission, complete remission.
Lois, we have another narcoleptic patient here. You know about it?
Yeah, oh yeah.
His name is Vern. Come here, Vern. Look at this. No kidding, this dog is a narcoleptic dog. Just let Vern... Vern, you can do anything but damage my rug. Come here, baby. Yes, a nice dog. What a nice baby, yes. Look how excited he is to be on the Donahue show. Okay, let's just, you're Vern's owner, are you?
Keeper, you might say, right.
Well, how often does Vern leave the,
Let's see, actually, I think if we get some dog food out here, we can see what happens when Vern gets excited.
We don't need the dog food.
Oh, there he is.
Yeah, he's kind of excited. Watch this. Can you see this, Brian? Get in there.
So I think it's very important to realize that sleep is an active process, and his brain, he is being taken over actively by a sleeping state. The mechanisms of sleep are overpowering him. So sleep isn't the brain turned off. Sleep is another way of brain functioning, and in this case, it's sort of out of control. So sleep-wake is an exquisitely organized process, and a little imbalance, and this happens.
I assume this animal, I'm sure you respect the rights of this animal, but this must be a valuable scientific vehicle.
Oh, absolutely. He
Research
mimics,
vehicle.
Vern mimics the human condition because people like the ones on the panel have this experience, but with people, it happens on the job, it happens while they're driving or in their marriage, and so it's a big problem. With Vern, he doesn't have any pain. It's not a big problem being a dog, and the other dogs don't treat him.
He doesn't have a boss wanting to know where he is.
That's right.
Can we go back to see Gary? Brian, let's go back. Can you hear me, Dr. Thorpe?
Yes, Phil.
How we doing?
Gary is starting to get into sleep. If we can have a look at the record now, we'll start to see some of his regular breathing episodes. And every so often he takes a very loud sigh as he takes a bigger breath. This is the beginning of seeing actual apneas. He's not having apneas.
Step back just a little bit so we can see that.
Okay.
I see.
There are wavy lines here which indicate the normal breathing process, but his breathing's starting to get a little shallow. Just back here we see a lot of activity. That's where he awoke because he had to take a large breath. Now he's gone into quieter sleep, and we would expect in a few seconds he would probably have another brief arousal. And soon we'll see these lines go very flat as he is unable to move any air at all in or out.
Let me pan over. Let's see Gary.
Took a large breath at that time. Brief arousal now. Then he'll go back into a deeper sleep, although he's still in very light sleep at this stage.
Okay. Apparently we will all be surprised to learn how many of us suffer from some kind of sleep disorder. Remember when you were a kid, you could sleep on cue? Except, of course, when your parents told you to go to bed. And then I assume there's a pattern here. As we age, sleep can become more of an ordeal, huh?
As we age, sleep in effect deteriorates. There are very few people where it seems not to, but in general, sleep deteriorates. A major change, there are two major changes. It becomes less continuous, more interrupted, and sleep disorders, particularly this sleep apnea condition and another condition called periodic movements during sleep, increase tremendously. So that
you want it down? I'm sorry, doctor. Excuse me. Come on, you can go here.
A recent survey of people over 65 indicated that 60% had a diagnosis of one of those two conditions.
Really?
So that's enormous numbers.
Susan Cooper is single from the New York area. You're 29, Susan. And guess what?
I'm a sleepwalker.
She sleepwalks. You know, all of us, or many of us do occasionally. Apparently yours was chronic, so?
Totally chronic. Over a period of about 15 years, I still, on occasion, have been known to do it. First started when I was about 10 years old, and I was standing in a window in London, England, about 7 stories up.
And you were how old?
10 years old. This, of course, freaked my family out to no end.
I bet it did. 10th floor, open window, and you're saying, what did you say?
I'm coming. No screens either.
Yeah. Well, talk to us here.
That pattern is a little unusual because sleepwalking is more common in young children. But there can be tremendous variability in when it appears, when it goes away, and so on. Generally, the pattern is to be present in young children and to gradually disappear as they get older, probably as sleep lightens, because I think we think of it is again the active sleeping brain generating this movement and being a little out of control, and then not being able to completely awaken. And so, although sleepwalking can be dangerous, as Susan just pointed out.
People can, you can't be coherent, though, can you, while you're sleepwalking?
Oh, that's not true.
Come
I
on.
was told.
Well, again, she's always coherent. I don't. Most people don't remember what they say, so that there's a really valid witness of how coherent they are. They're probably not too good, but here again, there's a tremendous variability. And I think one of the things also is that people actually can wake up, say something very coherent in the waking state, fall asleep immediately because they're so sleepy, and then not remember that. So the memory is erased. They say, oh, I must have said that during my sleep. Speech can be coherent. It's more typical, however, to be relatively incoherent, mumbling, totally inappropriate phrase, like it's a Western-type lament, and it doesn't seem to be related to anything. Or I'm choking, I'm choking.
How did you fix it? Or why don't you, did you do something about it?
Yes, I sought psychiatric help because obviously this is a psychiatric problem. And psychiatrists finally, after 15 years of this, a psychiatrist finally sent me to the Sleep-Wake Center at Montefiore and said, hey, maybe there's something physical. But nobody thought it was a physical problem.
And what was discovered?
That, in fact, my brain waves aren't working. Dr. DeMint,
Well, one would typically find that the episode occurs during sleep, and we can measure sleep and or wakefulness very accurately by recording brainwave patterns continuously. And to label this as a sleepwalking episode, you have to see that sleep is present when the walking occurs. So
How do you fix it?
well, the most important thing is to realize what it is and that it usually will go away if it's and to make the patient safe. As you said, she should never sleep on the 7th floor again. Was it the 7th floor? Or to be sure that there's no windows or doors or anything like that. The second, it can be treated with medication when it's very, very severe.
Are you on medication?
yes, mild sedatives that keep me from going into the deep, 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 deep sleep that used to cause my problem.
I see. You were very poorly diagnosed, weren't you?
Oh, yes,
Did you
over
wind
many
up-
years.
Somebody said you were schizophrenic?
Yeah,
You actually wound up in a mental hospital, didn't
for
you?
3 weeks, yeah.
Are you born with these disorders, or do you acquire them? And if you do acquire them, how do you acquire them?
Well, I think there's certainly a genetic predisposition for many of them, including sleep apnea. Narcolepsy is a disorder most clearly you're born with some abnormal gene that manifests itself in puberty. In the case of sleep apnea, there are many factors that contribute, such as weight gain. It's genetic in the sense that the airway structure is a factor. If you have a small airway, you're more likely to have it. The basic physiology, though, is you inspire. The sleeping brain isn't managing the airway as well, and you, in effect, suck the airway closed. Your muscles relax too much during sleep in some cases. So if the airway is smaller, that's more likely to happen. The most important thing in sleep apnea is it's much more likely to occur in males. People report anywhere from 5 to 1, 10 to 1, even 25 to 1. I think insomnia is very controversial. Many people feel very strongly there are personality factors, anxiety, depression, and so on. There's association with psychological problems, but it is by no means the major factor or cause of these problems in general.
Lois, your narcolepsy obviously interrupts your own life. It says here you've been married, you've been divorced. You're married a second time. This is none of our business, but it could be involved in problems with the relationship, couldn't it?
Oh, it's definitely involved because I'm very inconsistent. But that film was made 10 years ago. I think now that I know what I have, I can handle it a lot better.
Are there times when does the onset of the drowsiness happen during excitement, depression, fear? What?
The onset of the sleepiness will occur about the same times during the day. You're thinking now about an attack of REM sleep, which is when I would fall down. That's usually brought on by excitement, laughter, when I laugh.
Really?
Yeah.
Phil, I would add to that that during the year and a half between the discovery of my condition and the time it was addressed, I wound up sleeping in the guest room for that year and a half. Not so much because I was snoring so loud as to keep my wife up, but because I was sleeping so lightly that the slightest bit of motion or noise would immediately wake me up if I was sleeping at all.
Maybe we should review with Dr. Dement just a few basics. Most of us need 8 hours, true?
No, not true. Each person needs a unique amount of sleep, and almost all of us need more sleep than we think. To give the best example, seniors in high school spend 7 hours or less in bed. We now know that they need about 10 hours to be fully alert all day long. So
Seniors in high school?
yeah, by survey. So they are, in fact, very sleepy.
You mean our kids need more sleep than we do?
I think most of us need more sleep, including you, than we think. And we tolerate a sleep debt, if you will. We tolerate a degree of sleepiness. We cope with it. But if we are physiologically fully alert, we will not feel sleepy. We will not fall asleep at any time during the day.
Are most of your patients treated with medication?
Well, right now, the most common case that we diagnose is sleep apnea syndrome, and then that has a variety of treatments.
We've already mentioned one, surgery.
Surgery, medication, and there's what we call a mechanical approach, which is called continuous positive airway pressure, where you simply blow air gently into the nose, and that, sort of like holding a balloon open, splints the airway open and allows the breathing to go on all night. It's very effective.
Yeah, how much does the machine weigh?
Well, the machine itself, which is the compressor, is heavy, but it's by the bed.
But I mean, if you travel.
Oh, it would be like carrying a briefcase, I think. It's not that heavy.
Let me see Gary again, can we?
Phil, Gary's going into some very brief, what we call hypopneas, which are just like apneas, but they're shallow episodes of breathing. And his sleep becomes disturbed as he goes into these, and he has frequent arousals, which brings him into wakefulness, and then he goes back into sleep again. At the moment, he's in this recurrent stage. As sleep gets deeper, then he will stop breathing completely. But we're not seeing that process at the moment. Obviously, sleeping in this environment is not typical, and so...
No, well, that's we understood that. And we're grateful that he's being honest about this. Some nice folks might be tempted to fake it just for the sake of the show. We're grateful that he isn't doing that.
When we see apneic episodes, they are very dramatic, as Dr. Dement mentioned. What we find is that there is a complete cessation of breathing. The machine that we have on the top of the recording apparatus here measures the oxygen value, and we will typically find that the oxygen in the blood goes very low, sometimes to very life-threatening state, where the patient, if you were to see the patient when he's asleep, he would be quite blue in color. Then there's a loud snore as he would breathe up again, and the oxygen would come back up to normal as he goes back into another sleep episode and stops breathing again. So we get the recurrent cycle of it.
This must be some kind of lifelong distraction. First of all, you worry about not waking up. When you do wake up, thank God, you're tired, obviously.
Yeah, very tired upon awakening in the morning, tired.
And there's no... You wake up 700 times a night. Most of these awakenings are not recalled. And also there are cardiac heart irregularities. Probably the most dramatic thing that ever happened to me is I was standing looking at one of those paper records. This is when we first were becoming familiar with this illness, and we had an EKG going and the heart stopped. And I had never seen this. And at first I thought it was a machine, is a pin, what's going on? All of a sudden I realized his heart stopped. And it lasted about 10 seconds, and then, thank God, started again as he woke up. But we now know that frequently cardiac arrhythmias are associated with this. And it's due to tremendous changes in sucking air. That affects the heart rate. It affects slowing the heart, speeding up the heart, and if that gets out of balance, the heart can stop.
I was very conscious, I would say dozens, if not more times a night, of waking up, and my heart felt like it was going to fly out of my chest. And it was the most frustrating, exasperating experience of my life.
You have had surgery which opened your throat, is that right?
That's correct.
More than God had it open at the time of your birth, is that it?
Right.
Uh-huh.
And I believe that heredity played a part in my case because my father was a very heavy snorer, the kind who shook the walls. And when I walked into the sleep clinic, the very first question they asked me was your father a heavy snorer? And indeed he was.
Here's a tape of Gary actually having, what shall we call this? Listen, watch this.
This was recorded in the sleep laboratory a few nights ago, Phil. There he takes some big breaths. Now he goes into a quiet episode. He's trying to breathe. You can see his mouth moving as he struggles to try to get some air in. In a minute we'll start to see his chest movements and abdomen start to move. There we start to see the movement. He's trying to breathe, but his upper airway is obstructed. There's a little sound as he's trying to suck air through his mouth. Now he breathes normally. He's over the apneic episode. Takes a number of big breaths where he's able to get air into his lungs. Then he'll go back into sleep again. And
Gary, let me welcome you here today. What are you doing for Gary?
Well, we tested Gary the other night in the sleep lab, and we showed how severe his apnea was, and then the next night we were able to try him with a treatment device.
Yeah,
now, this is the record when he was having apneas, and I think you can see the very disturbed sleep. Breathing here, no breathing, breathing, and it's a recurrent process right through the night.
Yeah.
Then,
I mean, how long is it from here to here?
well, in that case, it's about 30 seconds. So these are 30-second apneas.
And the other side is what we were looking for, isn't it?
And then when we treated him with a treatment device, we can see here that it's continuous, regular breathing, very deep sleep.
What did you treat him with?
Sleep. This is with the CPAP device. Oh. Basically, it's an air pump. It blows air.
Oh, you have to wear that thing on your...
And he has to wear this every night. It looks impractical, but it makes a huge difference.
I'd like to know why you don't do surgery on Gary like you did on Ralph.
Gary was offered surgery at one stage because his apnea was so severe. But at that point, we felt that we could deal with the problem partially by weight loss. And we also felt in his case, which is a very severe form of apnea, that surgery wouldn't have relieved the whole problem in his case. Most patients with very severe apnea, surgery does, but not in Gary's case.